All right, thanks very much, and good morning to everyone. I hope you've had a wonderful time here. I've had a chance to look at the posters, and it brings back a bit of PTSD for me, actually. But thank you so much for being so committed to helping us prevent, hopefully, the next pandemic. I'm going to basically, because this is an international audience, I'm going to talk a bit about what the provincialized healthcare system looked like in Alberta. And then really share some examples of how innovations and evidence was integrated into the practice and policy during the pandemic. And then provide some recommendations going forward. I know that there's some forward thinking from this group about what things could look like going into the future, and I'll touch just very, very briefly on that. I just want to do a bit of land acknowledgement in Alberta. In Canada, we'd like to acknowledge that we are located on treaty lands, and in Alberta, we're located on treaties 4, 6, 7, 8, and 10, home and traditional meeting place of First Nations, Métis, Inuit, and all First Peoples of Canada, whose presence continues to enrich our vibrant community, and whose histories, languages, and cultures, as well as the elders and the knowledge keepers, they've gone before us. They bring us knowledge that we have to learn from, and we're so grateful that we're on these lands. All right, so healthcare in Alberta. Well, you know, healthcare in Alberta is very tumultuous, but there was a period where we did have some good years from 2009 to 2023. And when AHS was first created, it was created from 9 regional health authorities and 3 provincial entities, and emerged into a single province-wide integrated healthcare system. It was about the 4th largest company in Canada at that time. There's about 120,000 plus staff and physicians. The annual budget was about $16 billion. And what was really great about AHS was that there was really the ability to do large-scale scale and spread. There's a lot of cooperation that we had to build over time, and we were really able to standardize care across the province. So no matter where you lived in the province of Alberta, you could expect to get the same type of care. As I mentioned, this was the largest public merger, and you can see all the integrated services where we had joint ventures with primary care networks, but everything else was actually under Alberta Health Services. And in fact, we actually received an award in 2018 from the International Congress of Integrated Care as being one of the top 3 most integrated healthcare systems in the world at that time. This gives you a bit of just sense of the activity. There are about 106 hospitals in Alberta. There are over 8,000 beds, 2.1 million emergency visits. And you can see that this also included continuing care or seniors care. We had addictions, mental health, and we had 650 facilities and delivering programs and services to Albertans in addition to standalone psychiatric facilities. So one of the things that I really pushed on within Alberta Health Services was really about the focus on quality. Prior to that, everything was always about budget. And we know how budget it resonates with healthcare professionals. But we know that when you focus on quality, that savings will follow. And quality and outcomes was what is the passion for people who are in the healthcare system. So we really spent a lot of time building a culture of quality improvement. We had a physician dyad model, and if you think about it, it makes sense. Physicians account for 70% of healthcare costs. And so if you don't actually have physician leaders at the forefront of operations, how then do you actually make any improvements on quality care? We had standardized clinical pathways that we were able to roll out. As I said, we were actually well known to be one of the best scale and spread across the province, actually globally, with some of the initiatives that we launched. We also did some operational efficiencies called operational best practices. And over a course of about 4 years, we were able to generate savings of about $200+ million without laying off a single person. And this is really about half of it was non-labor, half of it was labor. And it was really about standardizing care in the labor environment and improving some of our non-labor practices like inventory management. And I've got stories of that, but I won't go into it right now. One of the things that we worked hard on was the strategic clinical networks, and courtesy of Dr. Cy Frank and Dr. Tom Noseworthy, who were visionary in sort of saying that, well, it's one thing to have a provincialized system, but actually how do we bring best evidence and practices into this health system? And so strategic clinical networks were created. They were created back in 2012. We had, at that time, and I'll show you sort of the progression of the strategic clinical networks, but it actually took a lot of convincing to pull about $20 million out of even out of a $16 billion budget to invest in these SENs. And these SENs were grassroots driven. They were multidisciplinary teams between academics and non-academics. And it was really about supporting a provincialized healthcare system to bring best evidence and how do we embed that into the care for Albertans. So this was the sort of the trend line of what had happened. We started off in 2012. You can see there were 6 strategic clinical networks. They were basically systems focused at that time. We realized that we were missing out on sort of operational entities like critical care, emergency surgery, so they came on next. Respiratory health, and you know, coming out to 2018, we then had 16 clinical networks. And what was really quite important was part of this work was that about half of the $20 million that we used to operationalize was actually used to invest in 9 large initiatives that brought best evidence into the system. And so this resulted in initiatives that led to scale and spread. So for example, if you wanted to have a stroke in Canada, the best place to have a stroke is in Alberta because you get the best treatment, the fastest treatment, and not only that, the rehab from stroke was spread across the province. No matter where you were, you actually got the same post-stroke care. So it's obviously not the current budget. SENs no longer exist. But just to say that these were some of the advantages of having the networks. You can see here that when we did an analysis, and we did publish this in CMAJ in 2019, that we had gross savings of, at that time, $178.74 million, with a return of investment of 1.54 for every dollar invested. And any time that we invested on any initiative, not only were we looking at it in terms of feasibility, we also wanted to make sure that it had impact. We were able to scale and spread. And very importantly, we're looking for a return on investment. This is a bit of an alien language, especially for academics. But because, as you can imagine, resources in the health system is limited, we wanted to make sure that there wasn't a return in investment and an ability to recoup some of the savings or some of the invested dollars. Hard cost savings is very hard to do in any healthcare system. So you can see here that we had hard cost savings of over $16 million. But what was really important was that we actually avoided 103,000 hospital bed days because one of our big challenges was capacity, and we saw that during the pandemic. But keeping up with capacity, Alberta is one of the provinces that grows the fastest in the country. And so we had to keep up with the capacity without increasing our beds. And this really avoided us from having to build another hospital, essentially. And at the same time, it improved patient outcomes, patient experience. We created pathways. And what was really important is that we leveraged another $65 million that we brought into the province through other funding agencies. So this is healthcare systems in terms of cost. We were always criticized in Alberta Health Services to be one of the most expensive healthcare systems with mediocre outcomes. That just sometimes I have nightmares about that during those times. And so through all of the work that we did on quality, through the work that was done by the strategic clinical networks, through the operating best practices that I talked about, we went from being the most expensive to now being 6th in the country, and we were the only one that was able to bend the cost curve downwards. And I think one of the challenges for any healthcare system in Canada in particular is that we don't actually get enough of a time of stability and leadership to actually make these things come to fruition. So in the 6 years that I was able to oversee AHS, that was enough time for us to do that. I can tell you that that cost has now gone up again, unfortunately. So how does that lead us to the pandemic response? Well, we know that when we had H1N1 back in the 2000s, that there was a lot of learnings from that, and that we could do better. And so we did some of that learnings, and one of it was really around the governance of how do you actually talk within regional health authority, with the provincial government, with the federal government. And we knew that there was a lot of mishaps and gaps, especially around communications, who was doing what, accountabilities, role clarity. And so you can see that when we actually went into the pandemic, which in my opinion is the biggest test to any healthcare system, we actually had things somewhat figured out. In that, Alberta Health Services, we had an emergency coordination center that we set up right away. We actually started setting that up in December of 2019, even though our first case in Alberta was March 5th of 2020. But we knew it was coming. You could read the landscape with the global spread. And so we were really trying hard to be in advance of that, with very strong connections with the provincial government, the government of Alberta, through the Ministry of Health. They also had set up an emergency coordination center, and through that we also had connections with the federal government, and in particular the Public Health Agency of Canada. So I'm really proud of the AHS pandemic response, and I just want to acknowledge for those of you who are here from Alberta Services, what an incredible job everyone did in the organization. For the first time, we all had to row in the same direction. The pandemic, COVID-19, was the 5th natural disaster that Alberta has had over the past 15 years. But the difference between the previous natural disasters, which included fires, floods, was that those are somewhat focused and localized to certain geographic areas. The pandemic affected every single person in the organization. There was nobody who was not affected. And so you can see some of the things that we did around expanding our ICU capacity. I was really proud of the fact that we never had to ship any patients out of the province for care. In terms of COVID testing, at one point, we were testing the highest number of tests per capita in the country. Contact tracers, they became so important during the pandemic. We went from a baseline of 50 to over 3,000. We maximized the use of virtual care, phone calls. We had, ASI stands for Alberta Surgical Initiative. We had a backlog of surgeries, as with every single system, but prior to Wave 4, we were actually able to catch up on our backlog, again with coordinated care and centralized appointments. And then First In, we were the first to develop an online assessment tool that was used by the United States, Europe, parts of Europe. We developed a vaccine booking tool. We had a PPE modeling tool that saved us in terms of being able to keep ordering our PPE 4 weeks in advance. And I'll show you an example of our early warning system. And the reason why all of those are important, because those are all aspects of learning that the organization had to do in order to keep up with the ongoing demands of the pandemic. I just want to show you an example of PPE usage, just because it's so impressive. This is the percentage of usage over the baseline, and you can see here how impressive it is. And if you've never really gone through a pandemic, you would never be able to guesstimate even close to what your usage was. But because we had a provincialized system, we knew exactly the burn rate of every single aspects of our PPE. So I'll give you an example. So for surgical masks, before the pandemic, our average burn rate was about 44,000 masks that we would use in a day. At the peak of the Delta wave, we were up to 750,000 masks per day. How do you even predict that? And so we were able to use some of that data initially to actually model out 3 to 4 weeks in advance. So we knew exactly how much we needed to order, as well as being very strategic about diversification. And just coming back to the PPE issue, one of our biggest challenges around PPE was also because we knew we were going to be limited, and I'll give you an example. And Dr. Jaffe is here, who was in AHS at that time, but he was dealing with our N95s, because we knew that our N95s would be cut off at some point from the United States. That was where the bulk of our N95 masks was. And so surely, we predicted right, the US cut off the border for us, and so we weren't able to get American-made N95s. At that time, we were already sourcing Europe, but it was going to be a bit of a delay. So we asked Mark to say, Mark, how can we reuse our N95s? And those are examples of some of the research topics that we wish we had evidence for, but we did not. And so, really goes into your thoughts for the future about how to really align some of the questions that we had during the pandemic to sort of research that we can use into the future. So we had really great collaborations. This is just an example of some of our key initiatives with industry. Industry really stepped up big time for us. And so, for example, we had a ventilator project, and we worked with a company that was out of Calgary, And they created what we call Bertie ventilators. And I think we have still 200 plus stored somewhere in the system that could be used on short-term notice. But at that time, we were really worried about ventilators because it was very hard to source. We were really worried about the mass casualties that was seen in Italy and in New York, and because we didn't know what was going to happen in Alberta. We had prototyped PPE. You can see again, we prototyped face shields. At one point, plastic was really hard to get. So, how do you actually work? And so we were working with companies that were doing 3D printing to see if we can develop some of these. And then apps for tracking, apps for communication. Those are some of the things that we were working with industry on. And then obviously our hospital surveillance system, having lab data integrated with daily reporting of positive cases was really, really important. We were able to drill it down to unit, whether it be at the hospital, location, wherever, but these are real-time systems, and they were updated about 3 times per day. So it really allowed us to really have that available information to plan and go forward. And again, it's because we had the provincialized system that we were able to have this type of detailed data. And so this led to some work around early warning systems where we were able to now use this data to help us predict about 2 weeks out about what our capacity demand was, both for inpatients as well as for ICU beds. So we were always predicting for the worst scenario, so that would be the one in the red box, so the red numbers were what we would be looking at, and we'd be planning our capacity and maximizing our redeployment to get our staff sourced into those units. So what came out of our strategic clinical networks and what was really, really vital to our pandemic was something called the Scientific Advisory Group. So you can imagine that as the evidence was changing on a weekly basis, there was no way that the system was going to manage that. We had nobody to really do that work, but we did have the strategic clinical networks. And so we asked them to change their focus on what they were doing in the SENs and to create this, what we called SAG. So multidisciplinary team of clinicians, researchers, we had operational leaders in there, other experts, and basically their job was to give us rapid reviews of emerging evidence and guidance from international, national, as it relates to things that we need to change during the pandemic. It was co-chaired by Drs. Lenora Saxinger, who's an ID specialist at U of A, and Braden Mans, who was at that time our ACMO for SENs. And it's quite amazing what they did. They did over 100 reviews. They worked as hard as anybody else in the system. And the topics really helped us decide on masking policies, on visitation policies, on how we screen for workplace programs, effectiveness of treatments, really seen as leading edge. I know that it's open access if anybody wants to see that, but I would say that that's a really good source of information to look at the questions that the health system was asking the academics to help us with. And clearly, much of it did not have evidence, or they were able to pull as much as they could. So that actually is a really good blueprint in my mind for you to think about as you go forward about what kind of evidence do healthcare systems need. So just a few remarks on closing. We know that there were a bunch of post-pandemic consequences, and we're still going through that, and we know that it's going to take us years. I've kind of correlated COVID-19 to a war across the world, and we're sort of in the post-recovery phase right now, but it's going to take us, I would say, at least a decade, and we're still struggling, I know, with everything going on, especially in Alberta right now. And sort of preparedness for us in terms of the system post-pandemic, really, we need to be smarter now, and I think we can't lose and waste the time that we have now until the next pandemic around some of the absolute foundational elements that are needed, like the infrastructure pieces, including primary care. One of the gaps in Alberta was that we really did not have the strong partnership with primary care that we should have had, nor were we able to pull them more into the system to help us with the response. The data, utilization, predictive analytic tools are really important. And especially the data across the country. We're very limited in Canada. PHAC did not have a good database that reflected all the provinces. And so I know they're working hard. We actually do have a strategic plan for data analytics across the country, but it really is going to take every province to step up for that. The capacity planning, we're very much accused about not having enough capacity. And at one point I was asked, well, Dr. Yiu, why don't you actually have the same amount of capacity that Arkansas has? And I would say to the politician at that time, well, you know, we're a very different system than the US system. We have different drivers, different incentives. And so, you know, capacity for them is revenue. Capacity for us is expenditures, right? Active surveillance systems, obviously we're very proud of our lab systems because we were one of the first to be able to create the recipe that actually resulted in the ability to identify COVID. And then that was spread across the country. And then the diagnostic capacities, and obviously investing in our healthcare workforce, especially in public health. So with that, I'd like to thank you for your time, and we're happy to answer any questions then.